Hello, so welcome to the part 2 of our topic about stroke and TBI. First, let's talk about the pathophysiology, the manifestation, and the management for stroke. So these are the classification of stroke. First is your TIA, or transient ischemic attack. So the patient is suffering basically of symptoms such as weakness or facial drooping that can be resolved within 24 hours. And your TIA is usually the sign of impending stroke. While in RIND, symptoms usually exist or can be resolved within 1 week. You have stroke in evolution. Patient experiences progression of neurological symptoms because he or she may not reach his or her stable neurological deficit. And then lastly, the completed stroke. Basically, the patient experiences stable neurological deficit. Let's go now to the pathophysiological classification of stroke. Basically, there are four. First is your thrombotic stroke. And your thrombotic stroke is the most common type of stroke. Usually happens at night. Its rescue drug is thrombolytics. Thrombolytics are usually your urokinase and streptokinase. Embolic stroke. So emboli, they are dislodged thrombus. They are sudden onset. Its rescue drug is also a thrombolytic. You have your lacunar stroke. Which among the stroke classification has the best prognosis? It can be pure sensory or pure motor. Then lastly, you have your hemorrhagic stroke. Remember that it has the highest chance of death. Its rescue drug is osmotic diuretic, or also known as mannitol. So these are the manifestation of left hemispheric stroke and right hemispheric stroke. So remember, in your left side, the code is RAINS. Right and left discrimination deficit, aphasia, ideomotor ideational apraxia, number alexia, and then lastly, slow in organization and performance. Ideomotor apraxia is defined as movement is not possible upon command but may occur automatically. And then ideational apraxia is defined as purposeful movements is not possible either automatic or on command. Number alexia could be acalculia. Let's go now to the right hemispheric stroke. So these are the manifestation. Dressing apraxia is defined as a patient has inability to groom well. Let's go now to the specific manifestation depending on the arteries affected in stroke. So you have MCA stroke. So these are the manifestation. So take note that in your MCA stroke, upper E is more affected than the lower E because your MCA supplies the upper E and the trunk. So as for differential diagnosis, take note of the aphasia. So in main stem MCA, it could be global aphasia. In upper division, that is Broca's aphasia. And in lower division, that is Wernicke's aphasia. Also, in lower division MCA, there is no weakness. Next is your ACA stroke. So ACA usually supplies the lower extremity. So if there's weakness or hemianesthesia or hemisensory deficit, basically the lower extremity is greatly affected than the upper extremity. Then you have your parotonia. Or also known as Gegenhalten. Gegenhalten syndrome. That is defined as increase in the tonicity of the muscle. And what differs parotonia from your hypertonia is that your parotonia has no clasp knife phenomenon. Or basically, that is give way phenomenon. You have your akinetic mutism, or also known as abulia. Perseveration is defined as patient utters the same words repeatedly. Next is your PCA stroke. Basically, in your PCA, the main problem is on vision. So you have visual impairment, visual agnosia. Visual agnosia, which is defined as inability to recognize familiar things. Prosopagnosia, which is defined as inability to recognize familiar faces. Just add color blindness. Next, you have Dejerine-Roussy, or also known as thalamic pain syndrome. Then you have your alexia without agraphia. Let's go to the brainstem strokes. So here, take note of the name and the areas affected. So these are the manifestations. Let's go now to the assessment. So you have your Brunstrom stages of recovery. So basically there are 6 stages. So you have your spared muscles in synergy pattern. The code there is Flat's edema. So that is your finger extensors, latissimus dorsi, ankle evertors, teres major, and serratus anterior. Let's go now to the abnormal reflexes. First is STNR, or symmetrical tonic neck reflex. So, it can be elicited if the neck is flexed. So the response is upper E is flexed while lower E is extended. But if the neck is extended, its response is upper E is extended while lower E is flexed. Then you have your asymmetrical tonic neck reflex, which can be elicited via rotation of the neck. So the response in your ATNR is on the ipsilateral side, upper E and lower E is extended. And on the contralateral side, upper E and lower E is flexed. Then you have your associated reaction. Usually occurs again on stage 2 Brunstone. So you have your SOX phenomenon. So it can be elicited if the upper E elevates. So the response is fingers are extended. Then you have your Reimers, or also known as abduction-adduction phenomenon. So you need to resist the good side. It's either abduction or adduction. The response is the bad side also abducts or adducts. Then you have your homolateral limb synkinesis. You need to resist the bad side, upper E flexion. So the response is lower E flexion of the bad side also. And also vice versa. So if you resist lower E flexion, the response is upper E flexion also on the same side. Then you have your hyperreflection. And you have your clonus, which can be seen again on stage 3 Brunstone stages of recovery. Then you have your Babinski-like reflexes, which is the positive side is extension of the big toe and fanning of the other toes. So those are your Gordons, which can be elicited by squeezing of the calf muscle, Schaefer's, pinching of the Achilles tendon, Chodok's, stroking on the lateral heel, Oppenheim, which can be elicited by stroking on the anterior tibia. So all of their positive sign is Babinski. Then you have your aphasias. So remember, in your Broca's aphasia, that is the upper division of MCA, Wernicke's, lower division of MCA, while your conduction aphasia, the problem is on the arcuate fasciculus or parietal operculum. So your Broca's area is a problem in motor. While in Wernicke's, the problem is on sensory. While in conduction aphasia, the problem is in repetition of words. Global aphasia is a combination of both. So you have problem in motor and you have also problem in sensory. So if you want to memorize specific aphasias, so this is the table. You have your anomia. Mainly the problem is on naming. Conduction aphasia, transcortical motor, Broca's, transcortical sensory, Wernicke's, mixed transcortical or isolation. Then you have your global aphasia. Now these are the management for stroke based on principles. So PNF, which is founded by Knott and Voss, the NDT, or neurodevelopmental technique, which is founded by Bobath, movement therapy, which is founded by Brunstrom. So remember that Bobath and Brunstrom have different types of technique. Bobath does not allow primitive reflexes, while in Brunstrom, they uses primitive reflexes for training. Sensory motor approach, that is for Rude's technique. Then lastly, you have MRPs, founded by Carr and Shepard. So that ends our part 2.